All right. So do you guys feel like you made any, excuse me, any progress? Good. All right. So the uh, the next one or concept that we need to talk about is pernicious anemia, and that one is on page 814 and also 816. So we skipped page 815, and I'll show you why. Um, so on page 814, pernicious anemia, um, all right, so this is essentially a vitamin B12 deficiency. And the reason it is a deficiency is because in order to, and you all should know this from previous classes, especially anatomy and physiology, in order to absorb vitamin B12, you have to have an intrinsic factor. And this intrinsic factor is a substance that is secreted by the mucosa of the stomach. So it talks about causes of vitamin B12 deficiency include these type of patients. Patients who are on vegan diets or diets that do not have enough dairy products, patients who have had small bowel resection, chronic diarrhea, diverticular, tapeworm, or overgrowth of intestinal bacteria. Further says anemia resulting from failure to absorb vitamin B12, which is pernicious anemia, is caused by a deficiency of intrinsic factor, a substance normally secreted by the gastric mucosa, which is needed for intestinal absorption of vitamin B12. So that's something I have read. Now, also what's important here is the signs and symptoms of someone who has vitamin B12 deficiency, anemia. It can be mild, it can be severe. By the way, this is on the right side of the page. I guess maybe third paragraph down, starting with B12 deficiency anemia. Anyway, so actually, let's see, one, two, maybe the fourth paragraph down, starting with causes of B12 deficiency include vegan diets. Now, as far as some of the symptoms that you might see in these patients, and one of the big ones that really stand out that you might see on your HESI as well as your boards, you'll see pallor, jaundice, glossitis, and glossitis is a smooth, beefy red tongue. So remember that, glossitis, smooth, beefy red tongue. There might be fatigue, weight loss. Patients with pernicious anemia may have paresthesia, which is an abnormal sensation in the feet, hands, and poor balance as well. Because B12 is, normal B12 contributes to a healthy neurological system as well. So that's page 814, and on page 815, no, 16. Here are some of the foods that are high in vitamin B12. Vitamin B12 starts with I guess that's the first paragraph on page 816 on the left side of the page. Vitamin B12 deficiency anemia is managed by teaching the patient to increase his or her foods with rich vitamin B12, which would be your animal proteins, fish, eggs, nuts, dietary products, dried beans, citrus fruits, and green and leafy green vegetables. Also, vitamin supplements may be prescribed when anemia is severe enough. Patients who have pernicious anemia are given also vitamin B12. They're given vitamin B12 injections weekly at first, and then monthly for the rest of their lives. So Remember that because those are the type of answers that you have to know. Oral B12 preparations and nasal spray or sublingual vitamin. I got some feedback. So the nasal and sublingual vitamin B12 preparations may be used to maintain vitamin levels after the patient's deficiency has been corrected by the injection. So they may do the injection for a certain period of time, and then in order to maintain those vitamin B12 levels, these patients might require the nasal spray or the sublingual type of preparation. So read that little section. There's not a whole lot on that one. All right, so that's vitamin B12. All right. Now, as far as AV fistula and dash normal, which is your next concept, what I want you to think about here is that bruit that I always tell you guys about, you know, that fistula that's inserted in the arm. It will have a bruit, meaning if you take the belly of your stethoscope and you place it over the fistula, you'll get a kind of a whoosh kind of sound. And then if you place your hands on top of the fistula, it'll feel like kind of like electricity going through your fingers. You also want to assess for neurological and circulatory issues as well. So that's your assessment. Can the patient feel anything? Can the patient, make a fist? Is there a good distal pulse, radio ulnar pulse? What about the color? Is there normal color, or is it cyanotic or ashen, or is there some compromise in the patient's circulation? So in my one of my PowerPoints, I think for chronic renal failure, there's some information about the bruit or the thrill that you can take a look at as well. That should be in the one entitled AKI and CKD. Let's see. Now look, let me tell you all something. So this should tell you all something. We have went over quite a few concepts. So you probably say to yourselves, you mean to tell me those folks missed that many questions or didn't perform that well? Yes, that's what I'm telling you. Yeah, so on that presentation in my module, your course tile module, it says AKI and CKD disease, nursing 1650 care. And on slide 17, maybe towards what's under HD vascular device or access, which means hemodialysis vascular access, maybe a few sentences down. It says, talks about the fistula. I will read that's those sections there because that's important. Let's see, where is it? All right, so I have here, I'll go ahead and make this in red because, no, I didn't want to do that. Let's try pink. All right, so you want to assess for circulation in the fistula or graft, and in the lower portion of the arm, check distal pulses or capillary refill in affected arm. Also check for bruit, auscultation, or thrill, palpation. So one, you listen, that's the bruit, and the other is you feel for the thrill. Feel the thrill. Yeah, you use that as a kind of a you know, catchy phrase. Maybe help you all to remember. You know, no, I couldn't be a rapper. Um, let's see. Yeah. So I would certainly look at that information under HD vascular access, slide 17. All right. So we pretty much covered that, which is good. You know, it's kind of weird, but when you think about all the time that I spend on heart failure, and then you only get maybe a couple of questions, isn't that crazy? Yeah, it's like, really? I guess it's because they know you're gonna hit that. You're gonna see a lot of it now, so it is still good to know. But I just think it's just really weird. All right. So diabetes two, type 2 diabetes mellitus on page 1286 through 87. Um, in volume 2 of IGGY. That's all they actually mention here is that's all they mentioned was diabetes type 2. So what I'm thinking is that it might be possible that they're talking about some of the risk factors. So what I want you to do on 12 on page 1287, table 64.5 on the right side of the page towards the bottom, it talks about indications for testing people for diabetes type 2 or type 2 diabetes. So these are just basically risk factors. Testing for diabetes is considered at any age in adults with a BMI of greater than 25 kilograms per m. With one or more of these additional risk factors. So in addition to a patient having or being a large patient, these are other or additional risk factors. If you have a first degree relative with diabetes, that means a sister, your father, your mother, especially your father and your mother. Let's see, risk factors. The patients are physically inactive. You are a member of a high-risk ethnic population, African Americans, Hispanic American, American Indian, or Pacific Islander. You have a baby that weighs more than 9 pounds or have been diagnosed with GDM, gestational diabetes mellitus. If you're hypertensive with a blood pressure of greater than 140 over 90, if you have a high density protein, HDL cholesterol levels less than 35, and if you have a polycystic ovary syndrome, if you have an A1C of greater than 5.7%. So go ahead and read that. The rest of that information is not much. And type 2 diabetes is a progressive disorder on page 1286. On the right side of the page towards the bottom, it starts at the title of this section is type 2 diabetes and metabolic syndrome. And so type 2 diabetes is a progressive disorder in which the person initially has insulin resistance. Their cells are resistant to insulin. And this progresses to a decreased beta cell secretion of insulin. Remember, the beta cells, not the alpha, but the beta cells of the pancreas is what produces insulin. And so you have a decreased beta cell secretion of insulin. Insulin resistance means a reduced cell response to insulin. So your cells just can't respond to it. So that sugar remains on the outside of the cells instead of inside the cells where it needs to be, right? Insulin resistance develops in patients who are obese, physically inactive, and genetically susceptible adults. It occurs before the onset of type 2 diabetes and often is accompanied by cardiovascular risk of hyperlipidemia, hypertension, increased clot formation. Many, but not all, patients with type 2 diabetes are obese. The specific causes of type 2 diabetes are not known, although insulin resistance and beta cell failure have many genetic and non-genetic causes. So read all of that and read also the section with metabolic syndrome. All right, for this one, it talks about a metabolic syndrome is the simultaneous presence of, that means all these are occurring together at the same time, presence of metabolic factors known to increase risk for developing type 2 diabetes and cardiovascular disease. And some of these features will include an abdominal obesity, so someone who has a waist circumference of 40 inches or more for men, 35 inches or more, 35 inches or more for women. So 40 inches for men, 35 inches or more for women. There's also a hyperglycemia, meaning fasting blood sugar glucose level of 1,000 or more, or on drug treatment for elevated blood glucose levels. Also for hypertension, systolic BP of 130 or more, over diastolic pressure of 85 or more, or on a drug treatment for hypertension. And also hyperlipidemia is another one. So go ahead and read that section. Any one of these health problems increases the rate of atherosclerosis. You know that the buildup of plaque in your blood vessels, and a risk for stroke, coronary heart disease, and early death. So go ahead and take a look at your metabolic syndrome that is also located on 1286, 1287. So that's kind of like two we just hit right off the bat there, was the type 2 diabetes. Just for the heck of it, go ahead and just in case, read page 1288. On the left side of the page, it has a heading, assessment, noticing, and it talks about history. And read that information all the way up until laboratory assessment. You don't have to read beyond laboratory assessment. So it's maybe a couple of paragraphs. This talks about the assessment part of it, things to look for. Just to be on the safe side, because like I said, this particular concept is rather vague. All right. Raynaud's self-care. So in your volume 2, page 741. Volume 2 of IGGI, page 741. We're talking about Raynaud's self-care. Remember Raynaud's phenomena. Raynaud's phenomena is an arterial occlusive kind of a disorder. All right, so there's a table on 741, page 741, table 36-7, and it talks about Raynaud's phenomenon disease. And this is where they're talking about painful vasospasms of arteries and arterioles. Remember, you have your arteries first, and then that branches off into arterioles, which are smaller arteries, before it branches off into like your capillaries. This is more particularly in the extremities, especially the digits, right? The digits. Now, this is what's really distinctive about this disorder. It causes a red, white, and blue skin color changes on exposure to cold or stress. The cause is unknown. It does occur in women more and may be an autoimmune component, right, or cause, because it is associated with rheumatic diseases such as lupus. As far as interventions, it's the same interventions for Buerger's disease, and that means these patients would be on vasodilating drugs such as Procardia. There's also management of ulceration and gangrene, because remember, if those spasms are severe enough and you get decreased circulation to the extremity, then that part of your extremity beyond that point of occlusion will begin to die. And so will result in ulcerative formation and possibly death of that extremity. And then you want to also consider chronic pain management modalities, because these patients have a lot of pain. Now, as far as nursing implications, remember, again, it's the same for Buerger's disease. Teach patients about smoking cessation, avoiding cold by wearing gloves and warm clothes, managing stress. These are the self-care concepts. Managing stress, avoiding caffeine, teach patients taking nifedipine or AKA Procardia to avoid grapefruit juice to prevent severe adverse effects. That's very important. Avoid grapefruit or grapefruit juice. Because the adverse effects can include death. So you have to really make sure they're being taught this information. Also teach the patients on vasodilators, because remember, this is dilating those blood vessels. Teach them about the side effects such as facial flushing, hypotension, and also headaches. So that's on page 741. Read that chart. It's a very small amount of information. And remember that characteristic red, white, and blue color. I think I got the wrong book for this one. Let's see, 1191. All right, this one may be in this other book. I think I may have wrote down the wrong book, textbook, on this next one. The next one we'll be talking about dehiscence, wound dehiscence. And this is when a wound just opens up due to different factors. Yeah, I had that in the wrong book.
It's on pages 277 and 278 in
which one do you have?
volume 1 of our med surge book. And it starts on 277 and goes to 278, and it's a picture.
277. Yeah, 277. All right, you guys can go ahead and read that one too. And it's under impaired wound healing, page 277 in volume 1. I also found it under in your fundamentals book. Your fundamentals book. On page 1191 to 1192, it actually talks about dehiscence as well. So go ahead and take a look at that. Think about those factors that may lead to poor wound healing, such as poor nutritional status or infection. This places these patients at risk. Also, patients who are obese, they have a higher risk of wound dehiscence as well. 1192 in your fundamentals book on the right side of the page, bottom right side of the page. You see it often happening in patients who are obese, especially when they cough. And once these wounds get infected, they will not heal. I don't care how long you have those sutures on there, it'll get worse if anything. So what they typically do is they take the sutures out, and it'll open up at that point, and then you place the patients, of course, on antibiotics if they have an infection, and you start packing the wound from the bottom up. And so the wound will heal from the bottom up. If there's an increase in serosanguinous drainage from the wound in the first few days after surgery, you want to be alert for potential dehiscence. I think this one really explains it very well. But you can check both sources. But I lean more towards your fundamentals book, because this is something you guys should have learned in fundamentals as a foundation of your nursing knowledge. Let's see. So colon cancer, specifically intestinal polyps. Page 1126. Y'all should see my desk, guys. I have books all over the place. No matter how I try to keep this office clean, I might as well just give it up. All right. So go ahead and read about polyps on page 1126, left side of the page, towards the bottom. It's entitled, or the header is polyps, and talks about the pathophysiology. Look at that. So sometimes they refer to polyps as precancerous tissue. And so you want to make sure that you instruct your patient to do regular screenings, especially when there's a genetic predisposition. So make sure you read that information. I'm just trying to see if there's anything else stands out.
What page?
It's volume 2 of IGGI, page 1126, left-hand side of the page. Oh, here it is. And read all the way through, read the section also, read the section of pathophysiology as well as interprofessional collaborative care. It says nursing education focuses on patient education, instruct the patient about the nature of the polyp, signs and symptoms to report to the healthcare provider, the need for regular routine monitoring or screening. If the patient had a polypectomy, meaning removal of the polyp, follow up a sigmoidoscopy or colonoscopic examination are needed because of an increased risk of developing multiple polyps. So you have to really encourage your patients to do routine follow-up. So read that whole section. Polyps and interprofessional collaborative care. It's not that much information to read on that one either. I try to go as direct as possible with some of these. All right. So the concept PACU blood pressure assessment is in your fundamentals book, page 1287. Uh, 1287 on the right side of the page, under circulation, but starting with assess circulatory perfusion by noting capillary refill, pulses, and color and temperature of the nail beds and skin. So read that little section, and also the section beneath it says the paragraph beneath that is a common early circulatory problem is bleeding and hemorrhage, rather. Blood loss may occur internally or externally through a drain or incision. So the drains that you see in your patients, it could be really bloody, as well as it can be internal as well, or through an incision. So either type of hemorrhage results in a fall in your blood pressure. So this is why in the PACU environment, post anesthesia period, you want to make sure you're assessing for a fall in blood pressure because it could indicate a patient is bleeding. Let's see. These patients will also have, if patient has hemorrhage, it can result in a fall in their blood pressure, an elevated heart rate, and respiratory rates. The pulse may be thready. The stool will be cool and clammy, pale skin, and the patient will be restless. So you notify the surgeon for these changes, maintain IV fluid infusion, and monitor the patient's vital signs every 15 minutes or more frequently until the patient condition stabilizes. So just go ahead and read the rest of that information. Those two paragraphs. Again, starting with assess circulatory perfusion, and end with the paragraph that starts off with a common early circulatory problem. And that's not much to read either. So the biggest thing is you're looking for shock, basically shock, hemorrhagic shock. Page 601. Page 601 in volume 1. I think. Yeah. So volume 1, page 601 in IGGI, under assessment, noticing. Who is this? Oh, I can't do that, partner. They're trying to summon me to another meeting, and I can't do another meeting. I'm in class. All right. All right. So under physical assessment, signs and symptoms, on the right side of that page, 601, and the 1, 2. Well, yeah. The third paragraph down, it starts off with crackles are heard with auscultation when fluid is in the interstitial and alveolar areas, and breath sounds may be diminished. Wheezing may be heard if inflammation or exudate narrows the airways. Bronchial breath sounds are heard over areas of density or consolidation. Fremitus is increased over areas of pneumonia, and percussion is dulled. So go ahead and read that section on just that one paragraph, actually, on page 601. Let me send one of the ADONs an email letting her know I'm with my people. Let's see. forecast meeting. I just wanted to make sure they know that I'm not trying to shirk a meeting. All right. So the next area to discuss is what we refer to as exothalamus, and this is on page 12. Try volume 2 of IGI, page 1265. Try that one first. Remember the bulging eyeballs that you see in patients with Graves' disease who have thyroid, the thyroid condition, that ugly picture. I shouldn't say it like that, but you know, not cute. That's for sure. No, remember I talked about that. I said that if you have hypertension, the goal is 130/80 or less.
Oh, okay.
Yeah. So you trying to make me go back? Yeah, I was trying to blow through some of them, you know, so that we wouldn't, you know. All right. So on in IGI, page 1265, under etiology and genetic risk, of course, you have the condition Graves' disease, which is the autoimmune type of disorder related to thyroid disease. Also hyperthyroidism. So in Graves' disease, all of the general symptoms of hyperthyroidism are present. So you still have all the diseases, signs and symptoms are present, but in addition, other changes specific to Graves' disease may occur, including exothalamus. So if you have a patient who has the autoimmune type of hyperthyroidism, Graves' disease, then you can expect exothalamus, the pretibial maxedema, but what we are more focused on is the exothalamus, which is an abnormal protrusion of the eyes. And on page 12, and by the way, that's on 1265 on the right side of the page, the second paragraph. And 1270, on page 70, towards the bottom, starting with the last sentence, it says, I envision problems of Graves' disease are not corrected by treatment for hypothyroidism and management. Wait a minute. All right, so I envision problems of Graves' disease are not corrected by treatment for hypothyroidism and management. Management is symptomatic. All right. So you teach the patient with mild problems to elevate the head of bed at night and use artificial tears because these patients may not be able to close their eyes all the way. And you don't want their sclera to dry out. If photophobia, which means sensitivity to light, is present, encourage them to wear dark glasses, which may be helpful. For those who cannot completely close the eyelids completely, recommend gently taping the lids at nighttime so they don't dry out. And these actions can prevent irritation or injury to the sclera. If pressure behind the eye continues and forces the eye forward, it could result in a decreased blood supply to the eye, leading to ischemia and blindness. So these patients must be taught to report increased pressure behind the eyes. All right, and read the rest of that information under eye and vision problems. And you can stop at don't go past cellular regulation concept exemplar hypothyroidism. So, so make sure you take a look at that. Pretty straightforward. Basically, you're taking care of the eyes. Let's see. You all remember taking cataract, studying cataracts in Adult Health 1? All right, so you're going to see it again. And see, this is the thing. Remember how I tell you all that the HESI covers what you did in the past, or previous courses, the course you're in now, and also covers future courses that you'll take. I know you say that, well, that's not fair, but eventually you're going to see that particular topic in your last term. So I guess they're trying to give you some kind of exposure or see if you can make any connections. You know, for example, if I'm talking about chronic renal failure, and let's say heart failure is not discussed until your 7th term. Well, if I'm talking about a CKD, it's hard to talk about CKD without talking about heart failure. All right, so they hope that you can make that connection, even though you haven't really studied it in depth. You know what I mean? So, but at least, you know, hopefully we're kind of hitting on some of these items that will be helpful. Cataract, the next concept is cataract post-op, in particular on page 970 in IGI volume 2. And under, on the left side of the page towards the bottom, post-op care. And so what's important about this one is the installation of antibiotic and steroid ointments that must be instilled. And make sure you read that chart 47-1 for best practice for patient safety and quality of care. It talks about installation of ophthalmic ointment. So they may ask you a question about that. So make sure you read that. The patient is usually discharged within an hour after surgery, and so you must instruct them to wear dark glasses outdoors or brightly lit environment until the pupils respond to light, because you know they're going to dilate their eyes. On the right side of that page at the top, teach the patient and family members how to instill the prescribed eye drops. Again, look at, see, what is this, chart 46? Where's that? Chart 46.
There's a good page 972. It's chart 47-2 that says the patient after cataract surgery.
What book is that?
That's the one we're looking at, the MedSurg Volume 2.
And what page?
So page 971, chart 47-2.
Yeah, you know, I was looking at this one where it says see chart 46-2. That's what had me confused. I don't see a chart 46-2. Y'all see that? Oh, that would be in, I guess, chapter 46. All right, so you can refer to that. Oh, yeah, you can read that one as well. Home care assessment, patient after cataract surgery. Read that one as well. It's not much. But also continue to read this other information on the right side of the page 970. Remind the patient about mild eye itching is normal, as it is as is a bloodshot appearance. So their eyes may be bloodshot. The eyelid may be slightly swollen. There can be significant swelling or bruising. Well, if the patient has significant swelling or bruising, that would be abnormal. Cool compresses is beneficial as a comfort measure. Discomfort at the site is controlled with acetaminophen or oxycodone. Aspirin is avoided because of its effect on blood clotting, so avoid aspirin. So just go ahead and read the rest of that information. Read the chart. And also on the right side of the page, read that as well. It talks about on page 971, left paragraph or left side of the page, starts off with pain early after surgery may indicate increased intraocular pressure or hemorrhage. Instruct patients to contact the surgeon if pain occurs with nausea and vomiting. To prevent increases in intracranial pressure, teach the patient and family about activity restrictions. Activities that can cause a sudden rise in increase in intraocular pressure are listed in table 47.2. Table 47.2, yeah, so this one is, this is the other table. Read table 47.2, activities that increase intraocular pressure. And these are things you want to tell your patients to avoid doing. So that's your cataract post-op. Not a whole lot of information, but just make sure you guys understand this information as we discuss them. Let's see. The next one talks about BPH nocturia difficulties. That's page 1474 in IGI, volume 2. 1474. And you can go ahead and start off with assessing and noticing on the history, and also read that section on physical assessment, signs and symptoms. It starts off with ask about the patient's current urinary elimination pattern, assess for urinary frequency and urgency, determine the number of times the patient awakens during the night to void, which means nocturia, and other symptoms of lower urinary tract symptoms. Difficulty in starting and continuing urination, which is hesitancy, reduced force and size of the urinary stream, meaning a weak stream, sensation of incomplete bladder emptying. So read the rest of that information. If frequency and nocturia do not occur with restricted urinary flow, the patient may develop infection or other bladder problems. So when these patients have an enlarged prostate, they are prone to developing bladder infections, urinary tract infections, because that prostate tissue is pushing on the urethra, and they're not able to empty their bladder fully, and therefore can result in urine that is stagnant and stale, increasing your chances of an infection. So many times what we do is we tell these patients not to drink within 2 hours of going to bed, avoid caffeine, alcohol, and so forth. They may place these patients on what we call, and I think it's an alpha blocker, but it's, what do you call it? Tamsulosin or Flomax. That's probably what you all are used to hearing. And that helps to relax the urethra, and then they can pee a whole lot better sometimes, you hope. All right, so make sure you read that. We just have a couple more to go, actually. So in volume 2 of IGI, on page 685, 685, the concept is ventricular fibrillation, immediate action, right? Start off with page 684 with ventricular fibrillation, the pathophysiology. But what is really also important is on page 685, on the left side of the page, first of all, look at that rhythm. So you can know that rhythm. That's ventricular fibrillation. And the second paragraph, it says, this is important. I don't know if that was you, Ms. Lynch, or somebody was talking about ventricular fibrillation, and do you electrocute first or do you do CPR first? Well, that was you? All right, here's your answer right here. Here's your answer right here. So, and see, this also spoke to what I was telling you. It depends on whether or not that electricity is available. So it says the desired outcomes of collaborative care are to resolve ventricular fibrillation promptly and convert it to an organized rhythm, because that rhythm is chaotic, it's disorganized. Therefore, the priority is to defibrillate the patient immediately according to ACLS protocol. That's advanced cardiac life support. It's the advanced version of CPR. Now this is what I was telling you. If a defibrillator is not readily available, high quality CPR must be initiated and continue until the defibrillator arrives. So like I was telling you, it really depends on the scenario. I mean, if they're telling you, if you get a sense that it's saying that the electricity is not readily available, that somebody went to go get the AED, then you want to start performing CPR, because say if it takes them 5 minutes to go and find that that AED. Well, if that happens, how long does it take for someone to be brain dead? How many minutes? 4 to 5 minutes. So you want to stand around and say, I'm going to wait till Ms. Cameron get back with the defibrillator, and then, you know, no. Because even in between defibrillation, you're doing CPR. But in this case, if the defibrillator is not available, start CPR, high quality CPR. Once it arrives, you go ahead and you shock that patient, because the electricity is certainly much more effective. And anybody can pretty much do, well, not anybody, but many people can utilize the AED. Pretty simple. It talks you through it. Make sure you're not touching the patient. When you deliver that shock, you say, I'm clear, everybody clear. Look around the patient, shock them. And you don't want to be doing CPR while the AED is analyzing the rhythm. Because if you do that, even though the patient may be in sinus rhythm, maybe they converted to sinus rhythm, but because you're moving that patient around, it's going to look chaotic. It's going to look like they're in ventricular fibrillation. So hands off while the system is, in other words, don't bother me, I'm analyzing. So let the system analyze. When someone is in ventricular fibrillation, the ventricles are what? Fibrillating. They're fibrillating. All right, they're not boom, 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 boom. Look at my fist, boom, 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 boom. They're not doing that. They're doing this. They're fibrillating, meaning you're not getting a good cardiac output. Your cardiac output is compromised. These patients, they will become unconscious. They're not getting good perfusion. They essentially don't have a pulse. They're dead, really. You know, but there is a chance with this rhythm that you can bring them back. Now, when they're in systole, you don't shock them. You know, like you saw on TV years ago. I think they still shock, but it's systole. They need to hire me for programs like that so I can tell them what looks real. You know how they have the patient is intubated and they have a little piece of white tape on the ET tube, and I'm thinking that looks so phony. You know. Yeah, it must have a bad setup, you know. Somebody really don't know what they're doing. Maybe I ought to write them and tell them I can make this thing look real good, right? I should. Never know how people get jobs. I don't know if you all remember this, but there was this nice looking couple on HGTV. They were in California and they flipped houses. The young lady was a blonde and she was married to this guy. I can't think of what his name. But they had these little beautiful daughters, like two or three of them. Anyway, so a nurse was sitting home and watching HGTV and noticed that there was a lump in this guy's neck. And then she called the studio and told the producer, hey, he needs to get his thyroid checked. Comes out the guy had thyroid cancer. Yeah, she saw that. And see, these are the eyes that you all would develop. You're looking at patients, looking at people in general, and notice certain things, certain things that are off, even though you can't explain it. So you get to learn that as a nurse. Let's see. Let me pull up this other one. So the last concept I want to go over is well, not quite the last because I want to tell you all something. All right. So they talk about the next concept is risk factors for hepatitis C. So let me read this to you. Actually, let me do this. So in your chat box, I just put a link to Mayo Clinic's website. It says your risk of hepatitis C infection is increased if you. It says are a healthcare worker who has been exposed to infected blood, which may happen if an infected needle pierces your skin. If you have ever injected or inhaled illicit drugs, if you have HIV, if you have a piercing or tattoo that is done in an unclean environment using unsterile equipment, if you received a blood transfusion or organ transplant before 1992, if you received clotting factors concentrated before 1987, if you receive hemodialysis for a long period of time, if you're born a woman, if you're born to a woman that has hepatitis C infection, is also a risk factor. If you're in prison, were born between 1945 and 65, the age group with the highest incidence of hepatitis C infection. Isn't that something? All right. So those are your risk factors there for hepatitis C. All right. So what I also wanted to go with you quickly, man, we really made good time. I think I was a bit too aggressive. I'm sure you all don't mind. Yeah. Let's see. So what I might do, let me do this first. So I may try to join that call and send you all back into study mode. So I told you all earlier that I provided the concepts for the most missed items. And so what I wanted to do is look at real quickly these other items, these other concepts. Let's see. Let's see, medical surgical, that's the final one, 908. Yeah, that's the final one. Yeah, I think that one's it. Right, let me, just bear with me. System is a little slow. Oh, there it is. All right, so I told you all that I used 70 something percent as my threshold. All right, so if 70 something percent and even lower students got the information wrong, so that means that we covered the majority of this. The only thing we did not cover is tracheal suctioning. So if you want to, just go ahead and look at tracheal suctioning. I believe it should be in your fundamentals book. Check that out. It's only 3 of them, actually. Also look at ulcerative colitis. This is another concept, bloody diarrhea. I don't know what in particular that it talks about, but make sure you take a look at that. And also paracentesis, evaluate. You know, these patients have a needle. Don't confuse that with thoracentesis. This one is paracentesis. So you're taking away taking away drainage from the belly, from the peritoneal cavity. When patients in particular have ascites, you know, fluid buildup in the abdomen. So those are only 3 that we didn't do. Everything else was 77% or below, and 0, well, believe it or not, as far as where they scored the lowest, hepatitis C, believe it or not. And that was easy to look up. I just went to Mayo Clinic's website. So hepatitis C, they score very low. Corticosteroids, which we went over that. Check your Mosby's book. Only 18% of the class got that right. The metabolic syndrome risk factors, I gave you that information, so you should know where to find it. Ventricular fibrillation, believe it or not, that was another one. Only 18% of the class got that right. Isn't that something? As far as BPH, only 23% got that right. BPH, nocturial difficulties, only 23%. Cataract post-op, not many people know about that. Exophthalmos, the same thing. Pneumonia breath sounds, now you got the information. So you need to make sure you understand that well. PACU blood pressure assessment or blood pressure goals, only 32%. Remember 130 over 80 or less. PACU blood pressure assessment, only 32%. Cancer with polyps, 36%. Dehiscence, wound dehiscence, only 36%. Same with Raynaud's self-care. Remember that table I provided? Type 2 diabetes, AV fistula, what's normal? All right, only 41% got that right. Pernicious anemia, only 41%. Same with prostatectomy, calf leaking. MRSA, only 45%. Skeletal traction, only 45%. See, y'all, all this is pretty significant. You know, y'all should know this stuff. Thoracentesis, positioning. That's another one, only 45%. Got that right. So this gives you a sense of how badly people have done in the past. Trousseau sign, you know, you're thinking about low calcium. This detects early hypocalcemia. So anyway, so it kind of goes up from there, 50%, 55%, a lot of 55%, 59%, 64%. Yeah, so even chemo side effects was at 68%. So anyway, so the pages have been provided for you. You got your concepts. You know where to look now. I was very specific and deliberate about where to go. This shouldn't be that long. So the other one was like 2.5 hours, and this one is like probably be a little more than an hour. So that shouldn't overwhelm the other group. And if you all want to go back and look at it, I'll make sure I convert this to a MP4 when we hang up. And I'm trying to think. I might send it to you via email, but I'll let you know where to locate it. Did you guys have any questions at all?
I do. Do we all have the same exact test, or do we all have kind of random SE questions about the same concepts?
I think you all will get the same version of a test, and I don't think they could scramble them a bit. You know, I'm not quite sure because I'd be so tempted to kind of like stand behind someone and just look at the questions as they're doing them. But I don't want to make anybody nervous. So, so I can't say if they're kind of like flip because even we have the capability as instructors to shuffle the answers around. So they could do that. That may be automatic. When we set up the HESI for you all to take it, there's certain settings we have to make sure that we set up. And that could be one of the features. I don't quite remember. But it is the same version though. You know.
A lot of the questions, do they relate to the HESI questions on the tile, the cohort tile?
Say that again.
Do a lot of the questions relate to like the cohort tile? Like, do they coincide with? Are they like parallel to the questions on there if it goes over the same topic?
You mean the topics that we've been discussing in this class so far?
Mm-hmm.
Yeah, give me an example.
Like the lithotripsy. Like there was questions about that on the cohort tile, the HESI example questions. Are they going to be like parallel to like the same kind of question, or do you not know?
Like the HESI questions that you all do, like in the on the cohort tile, NCLEX style questions. In other words, it should. Yeah. It should, because here's the thing. I mean, we're trying to prepare you all to take those same kind of questions. So I would certainly hope that that it should, because how else are we going to prepare you? I certainly don't want to give you one thing and then switch it up on you. That's no good. So yeah, they should be similar. The advantage that you guys have now is that you at least are more familiar with the concepts that you will encounter, as opposed to going in it blindly. And to tell you the truth, for example, we didn't go over, let's see, we didn't talk about paracentesis. We didn't talk necessarily about trach suctioning. Pursed lip breathing for COPD, we didn't talk about that. Chemotherapy side effects, no. Electrical burns, no. Pre-op labs, no. Pretty common, well, I won't say common sense, but pretty simple, common labs, if you will. What else? Diabetes, as far as blurred vision, we can cover that. So there's quite a few things on here that I didn't cover for adult health too. Not that I have time to either. No, you give me the concepts that I'm supposed to cover. I wish this test would just talk about what I talked to you all about. Just to see, because it tells me where I am as an instructor, and it tells me if you have learned the material. I don't think that there's necessarily a way to determine if I've been effective by looking at what I just went over with you all. It's really hard, So just like you guys, when I impress upon you to do the very best you can do on your HESI, because then it tells me where your weaknesses and strengths are. And so we can develop that plan to help you improve on those weaknesses. So I would like to know also. Obviously I can look at, these concepts, and when you all are done with the HESI, go back and look at the concepts and see what you all have done. And let's say, for example, my hope is, for example, if we're talking about GERD instructions. Right now, you're sitting at 50% in previous classes, but if that number moves for you guys to about 80-something%, 90%, then I know that I got the message across, if that makes sense. So and you know, I'm kind of looking at trends somewhat. Typically students, depending on, you know, really it depends on the situation, I guess. Did you have a consistent instructor? Did you have time to study? All these different factors and whatnot. But chances are you all would probably have some similar issues. I'm happy that I use 70-something% as the threshold because that seems to have captured most of these. So I feel like you have a more comprehensive, you know, idea of what to expect, as opposed to if I just went over maybe 6 of them, you know. So that would have been disastrous, let me tell you. So, all right. So make sure you all register. Register for tomorrow. Be at the school. Make sure you're not trying to rush. You know how you have to be there for to be sitting down to take your test. Actually, you'll be sitting down at 10 o'clock to do a survey first, and then we'll go ahead and perform your test. But you don't want to be coming in all stressed and out of your mind and anxious and all that because you're trying to fight traffic. You're worried. You didn't know whether you would make it to school or not. It's all right if you get to school at 9:30. You know, maybe sit in the car a little and relax. You know, decompress. Think about what you're doing. Be calm, cool, collective. It's all right to do that. Don't try to get there at the last minute, you know, and keep, not that I'm getting into your life, but you always want to try to keep the drama down as much as possible. When I was in nursing school, that is one thing I tried to make sure is that I didn't have many life craziness going on, you know, because I know that can affect how you do your, how you perform in school, academics. I have to have full brain power, you know, when I'm studying this stuff because some of it is so convoluted, you know, and I'm sure you all can attest to that. So get a good night's rest, you know, at least get at least 6 or 7 hours, you know. I know it's hard to say get 8 hours, but at least 6 or 7, I would be happy with that. Remember to wear your uniform. And I can't think of anything else I need to touch on. Make sure you eat a good breakfast. Not like right at 9 o'clock, but maybe 8 o'clock, 7, 8 o'clock and whatnot, something to hold you, you know. Make sure you're eating as well. We let you use the bathroom prior to taking the test so you don't be sitting there squirming in your seat. Can anyone think of anything else? No? Y'all ready? Somewhat? You'll be ready by tomorrow. All right. Well, I certainly hope this was helpful.
Very helpful. Thank you.
Yeah. Thank you all for being patient. I try to make it as least painful as possible.
So you're gonna upload this tonight?
Yeah. Well, I'm going to upload it hopefully within the next. Kind of takes a little time, you know, because I think I may have to upload it to my YouTube channel, and then get the MP4 link, and then I can send it to you guys in the form of an email. That way everyone can get it. So let me just stop sharing here, or rather recording.